The opioid crisis in America. 142 people die every day from drug overdoses, with more than 33,000 opioid-involved deaths in 1 year alone, according to new government data. President Trump addressed the deadly drug epidemic yesterday after being briefed on ways to fight the public health crisis. Listen.
Nobody is safe from this epidemic that threatens young and old, rich and poor, urban and rural communities. Everybody is threatened. The best way to prevent drug addiction and overdose is to prevent people from abusing drugs in the first place.
Joining us right now is Dr. Mikhail Varshavski, better known as Dr. Mike. Dr. Mike, good to see you. Thanks so much for joining us. And what you've seen this and its impact firsthand.
Absolutely. I mean, I'm on the front lines of this thing. I'm a primary care doctor. I'm working out of the emergency room. I'm working out of my office. And you see that patients that generally don't have addiction problems start developing addiction problems with these medications.
How?
So they're incredibly addicting. So even if a person doesn't have an addictive personality, as some may label it, they still have problems with these medications. And the reason, there's a lot of reasons why this happened. And a lot of it was not enough information from pharmaceutical companies about how addictive these medications are. Lawyers are actually to blame for some of this. And that's not something most people talk about or think about, because when doctors were originally prescribing these medications, it was because the burden was placed on them, and it's a burden, to make sure that no patient has pain. Because if a patient had pain, it means a doctor wasn't doing their job. But as we know, pain is subjective. So it's difficult to sometimes rule out who has real pain, who has feigning pain. And it put a tremendous burden on doctors to treat everybody with pain. And that's where we're stuck in this situation. People are dying, people are getting hurt, and it's hitting communities that were never hurt by drug addiction in the past.
Well, is the issue that these drugs are just too strong and too addictive that maybe we need to go to the drug company and dial back this medication?
So, as a drug, it is strong, but it needs to be strong because there's sometimes severe pain where you need excellent pain control. But it's important that it's not used for chronic pain. That's where education comes in. And not only education for the consumer, but education for doctors. Because what we did is we started thinking, well, how do we control this? How can we change the medication to be less, have less abuse potential? And we said, let's use it in a long-term, in a long dispensed form, meaning it takes longer to get released and it doesn't have that much of a high in your brain. But what we found is people just started crushing it and abusing it anyway and getting the same result. So it's important that doctors don't view that as a solution, because it's not. Really what the solution is proper education of our patients for short-term use of this medication, and on top of that, using alternate means of pain control. You have acupuncture, osteopathic therapy, you have other medications for pain that aren't as addictive. And it's really important that we focus on those methods before jumping to opioids.
May I raise a wildly unpopular idea, though, or part of the problem, that when you have these press conferences, when you have the governors of many states complaining about this opioid addiction problem, it also falls on personal responsibility. That if you go in for a sprained ankle, you should not be taking an opioid. That you have to be aware. And Toby Cosgrove spoke to this somewhat from the Cleveland Clinic about you need to educate people that you shouldn't. I mean, there are very few instances in your life, unless you say have stage 4 cancer, that you need to be taking some of these medications, and that you have to say no, and you have to know better.
Yes, but the average person doesn't know that if a doctor prescribes Percocet, that's an opioid medication. It's hard to know because there's different brand names for this medication. So it's difficult to put all of that onto the patient themselves.
I didn't say all, but at least some, because the blame has been spread around to everybody except to the person, the individual actually taking the drug.
Absolutely. I mean,
and buying heroin, which is illegal.
But it seems like these drugs are so strong that it kind of, once people get them, a chance to become addicted to them, you kind of, the drug's bigger than anybody out there, that anyone could become addicted to these after any sort of normal procedure where a pain medication's given.
I know plenty of people who've had to take Vicodin after shoulder surgery or some sort of orthopedic surgery, and that they're not addicted to opioids.
So the addiction potential rises really when the medication is not taken appropriately. When it's given after surgery for a short period of time, if you're having extreme pain before a surgery that's given, the abuse potential is low. And that's what our job as doctors is.
Cancer, for example.
Sure. you need to weigh the benefits and risk when prescribing anything or not prescribing anything. So if I'm judging whether or not to give an opioid medication, I have to see, is there abuse potential? Sure. But this patient's in pain, can't walk, can't live because they're uncomfortable. I have to weigh that benefit versus risk. So sometimes, even if there is a slight abuse potential for 2 weeks, I might have to give that medication because otherwise, what kind of quality of life is that? It's a thin line, but it's a line that doctors have to walk every single day. So it's difficult to just put all of the impetus on us to solve the problem. There is something we can do legislation-wise to help.
Dr. Mike, one thing, a person can go to you, get a pain medication. Then they go to another doctor and then yet another. They're getting triple doses of medication. There is no national database that say, I prescribed this pain medication that shows up so another doctor would say, well, didn't you just get a pain medication last week?
They're gaming the system.
Yeah.
Yes. So that's not the majority of the problem, but I would put that around 30% of the problem. And what's crazy is that when I work out of New Jersey and New York, and both states, I can go on the state database to see if they're what we call doctor shopping, going to multiple doctors getting these prescriptions filled. But if they go to Florida, I have no idea about it. And as a young doctor, I can't believe that that's happening. Because how can we not unite a network of information? That's all it is. It's a network of information. And because of states being territorial and legislative issues, we can't find out if the patient is doctor shopping. That's horrible because ultimately what I don't want happening is, number one, the people that are getting hurt are the ones addicted. So I'm not doing them a service by prescribing the medication. But then patients that are actually in pain are also being affected because I'm forcing them to jump through hoops, come back for more appointments because I need to make sure they're taking it the right way. They need to get only a short course in the emergency room and come see me when they're in pain. I'm making it more difficult for the person that has pain to get the medication. Unfortunately, that's a consequence of the medication having such a strong abuse potential.
Wow, incredible. Dr. Mike, good to see you. Thanks so much for weighing in here. Dr. Mike joining us there.